Welcome to This Explainer. Today, we're taking a microscopic journey straight into your bloodstream to uncover the science, the raw facts, and the hidden mysteries behind your HbA1c results. We're going to break down exactly how your body handles sugar and precisely how doctors track it.
But let's kick things off with a slightly provocative question to get you thinking. Does a high blood sugar reading automatically equal a diabetes diagnosis? Or could hidden biological anomalies, completely unrelated to what you ate for dinner, actually be deceiving your test results? Hold on to that thought because the answer might really surprise you.
Okay, here's our roadmap for today. 1. The science of glycation. 2. Daily glucose versus HbA1c. 3. Vein versus finger prick tests. 4. Decoding your target ranges. And 5. When A1c results deceive.
Moving right along to Section 1, the science of glycation. Let's look at that microscopic collision of sugar and blood.
To truly grasp what the HbA1c test is actually doing, we have to talk about a biological process called glycation. It's actually a pretty simple concept. Whenever you have glucose, sugar, circulating in your blood, it naturally sticks to hemoglobin. And hemoglobin is just the protein inside your red blood cells that carries oxygen. So the more sugar floating around in your blood, the more it permanently coats those cells.
And this is exactly why the A1c is such a powerhouse test. 3 months. That is the average lifespan of a human red blood cell, because that sugar is literally glued to the cell until the day it dies. Measuring your glycated hemoglobin gives your doctor an incredibly precise 90-day memory of your average blood sugar levels. Pretty amazing, right?
It's also fascinating to note just how tightly your body regulates this glucose. Case in point, if you're just sitting there completely sedentary and fasting, your brain alone is gobbling up a staggering 60% of your circulating blood sugar just to keep you alive and thinking.
Okay, Section 2, daily glucose versus HbA1c. We're comparing those immediate snapshots to long-term trends. Honestly, the easiest, most intuitive way to think about these two tests is like the weather versus the climate. Your daily fasting blood sugar, that's the weather. It's a quick snapshot, heavily affected by what you ate last night, how stressed out you are today, or even if you're fighting off a temporary bug. But your HbA1c, that is the climate. Because it measures that 90-day average, it's highly stable. It totally smooths out all those chaotic daily dietary swings.
If you're looking at comprehensive management, you really need both tests. Daily finger sticks give you immediate feedback on how your body's handling meals right now. But the HbA1c, that's your ultimate reality check. It shows how effective your long-term treatment and lifestyle choices have actually been over the last quarter of the year.
Which brings us to Section 3, vein versus finger prick tests. How the collection method fundamentally changes what your doctor can do with the results.
There's a very clear clinical divide here. A vein blood draw is done by a phlebotomist and sent off to a lab. It is highly accurate, and this is the specific method required to officially diagnose prediabetes or diabetes. On the flip side, you have the quick finger prick test. You get instant results in minutes using a lancet. It's absolutely fantastic for assessing your ongoing management, but because it's slightly less accurate, it is never used for an official diagnosis.
All right, let's get into the numbers. Section 4, decoding your target ranges, understanding international thresholds. So here are the 3 critical diagnostic thresholds you really need to remember. An HbA1c below 5.7% is considered normal. If your percentage creeps up into that 5.7 to 6.4% window, you cross into prediabetes. And hitting 6.5% or higher, that typically triggers a full diabetes diagnosis.
And I want to point out, these aren't just arbitrary local estimates. The World Health Organization uses these specific parameters, backed by rigorous quality assurance, making this a globally standardized diagnostic system.
In fact, the WHO states it explicitly right here. An HbA1c of 6.5% is recommended as the cut point for diagnosing diabetes. Now sure, a value less than 6.5 doesn't completely rule out diabetes if other glucose tests are waving red flags. But that 6.5% mark, that is the definitive international standard.
But what if you already have diabetes and you're actively managing it? Well, the goalposts shift just a bit. The American Diabetes Association generally recommends aiming for a target of 7% or lower. Consistently hitting that 7% mark is absolutely crucial because it's been shown to significantly reduce the risk of long-term complications, like nerve damage or kidney issues.
Now, for the really wild part of our journey. Section 5, when A1c results deceive. Let's talk medical anomalies, anemia, and genetic variants. Remember earlier how we said this entire test hinges on a red blood cell living exactly 90 days? Well, a really fascinating 2021 study published in the Iranian Journal of Diabetes and Obesity looked at over 700 people to see what happens when underlying conditions, specifically anemia, disrupt that biological clock.
The study highlights a massive blind spot in this testing. Because HbA1c is purely a measurement of time and sugar, any systemic condition that alters the natural lifespan of your red blood cells is going to feed the laboratory inaccurate data. It inherently forces the result to be falsely high or falsely low.
Let's look at how this actually plays out, starting with falsely high results. Things like iron deficiency anemia, vitamin B12 deficiency, high triglycerides, or even certain immunosuppressant meds. Basically, your cells are lingering around longer than they should, so they accumulate more sugar. You get a high A1C result, your doctor thinks your blood sugar is completely out of control, when actually you might just need some iron.
On the flip side, what triggers falsely low readings? Conditions where your red blood cells are dying off or washing away much faster than 90 days. We're talking hemorrhage, hemolytic or sickle cell anemia, kidney or liver failure, or even pregnancy. The cells simply don't have enough time to accumulate sugar. So you could get a perfectly normal, low reading that is actually masking a dangerously high blood sugar issue.
And it's not just about cell lifespan. Genetics play a huge role too. If you happen to inherit a hemoglobin variant, like hemoglobin C, D, E, or S, you have uniquely shaped proteins. Now, these variants don't cause diabetes at all, but depending on the lab's equipment, they can physically disrupt how the test measures the glycation, heavily skewing your data depending on your background.
Going back to that Iranian study, the data proved this defect perfectly. Among diabetic patients, the ones who also had anemia showed a statistically significant difference in their average HbA1c, 8.4 compared to 8.6 for the non-anemic patients. It just proves that a blood test is never just an isolated number. Context is quite literally everything.
So I want to leave you with a final thought to maybe bring up at your next doctor's appointment. The HbA1c test is an absolute marvel of modern medicine, no doubt about it. It gives us an incredible 90-day window into your metabolic health. But knowing what you know now about cellular lifespans, underlying anemias, and your own genetics, is your A1C telling the whole story of your unique biology? Keep learning, keep asking questions, and thank you so much for joining us on this explainer.